next presentation is on breast interventions. You know, the breast cancer has surpassed cancers of cervix and oral cavity in India, and it is the leading cause of death in India. So our next speaker, Dr. Parul Garg, will give presentation on breast interventions. She is additional director at JP Hospital, Noida. She is having experiences. Her presentation in state, national level CMEs and conferences on radiology. Now we'll have her presentation. Welcome, Dr. Parul.
Thank you so much, sir, for the introduction. I'll share my screen. So good afternoon, everyone. Thank you, sir, for the introduction. And thank you all for joining in here. I thank the organizers for giving me this opportunity to speak on this platform. So I will be talking about ultrasound guided breast interventions. So as breast cancer is increasing, so is the diagnostic capability of our imaging increasing. And we have many interventions which we can perform in the breast. Ultrasound is a very important modality for interventions, although we can perform breast interventions through mammography, which is stereotactic guidance. Then we have MRI guidance also, or sometimes even the CT guidance. But what are the advantages of ultrasound? It is less expensive and the most easily available modality, and it is quicker. And one of the very important advantages of ultrasound as a guidance modality for any intervention is that it is real time. It shows us the needle. It exactly shows where we are going into the lesion. It is a modality by which we can actually decide our trajectory to target our lesion where we are going to intervene. Then it is portable. We can often perform bedside interventions also, and it of course avoids ionizing radiation. So ultrasound, whenever we have a lesion, we often try that to visualize it on ultrasound because it offers it the ease of performing any intervention within the breast. Now, a little bit about the tough battles we have in any intervention field. The surgeons are often ready to operate or to do excisional biopsies. They often want to use the radiologist only as a guiding means of imaging, and they want to perform any intervention themselves. But I urge all the radiologists who are yet to start their practice, who want to start interventions, to take back and protect your field. Use the imaging guided benefits. Remember that you have a benefit of imaging the lesion and actually seeing it, which is above all your clinical fellows. So you should try to take off these interventions from your clinical fellows wherever this is possible to protect your field. Now, what all interventions we can do in the breast? So the simplest one of it is cyst and abscess aspiration. As anywhere, we can always have some cyst or abscess within the breast, which we can aspirate for symptomatic relief to the patient. Then we have fine needle and core biopsies, localizing wire placements, marking clip placements, and vacuum assisted biopsies. So I will be talking about them one by one. Now, before I take each and every topic, let me talk something about the basic trajectory planning in any ultrasound guidance. So the main advantage of ultrasound is needle visualization. So how will we visualize the needle well on ultrasound? So remember, like this, we have the probe here. Then we have, this is the image, and sorry. Then we have this needle. Now, how to decide in what angle to keep your needle with the probe so that you are able to visualize the needle adequately. So the physics behind is that whenever we have the probe and the needle angle nearing 90 degrees, then the needle will be visualized very well. See this image, the needle is visualized very well. And as we angle our needle so that the angle is less than 90 degrees, the visualization of the needle will be lesser as compared to the 90 degrees. But we have to always keep the needle in plane of the longitudinal axis of the probe with an angle to visualize the needle. So keep on rocking the probe, keep on moving the needle, and at an angulation, you will be able to see the reflective surface of the needle. So this is the in-plane method where the needle is parallel to the longitudinal surface of the probe with an angulation. So this is a basic trolley of our breast intervention, which is done under local anesthesia. So we have a sterile sheet on our trolley with a kidney tray with scissors, a forceps, an artery forceps. Then this is a 10 ml syringe for lidocaine installation. And we have this sterilizing agent, few gauze pieces. And this is a biopsy trolley. So we have a biopsy gun placed here. So we perform all these procedures under local anesthesia. Usually we require about 10 ml of 2% of lidocaine. Now, starting with the simplest of the procedures, that is cyst or abscess aspiration, I have a small video. Now, this we can see that this is a simple cyst in the breast, or maybe we can say it has some thickened walls. This patient had pain in the breast, and for her symptomatic relief, there was inflammation also around the cyst. We are trying to aspirate. See how well we can see the needle within the cyst. It is because we have angulated it. And see that the needle angle is almost 90 degrees. So it is very well seen. And we suck the fluid with the syringe and the cyst collapses. And after we suck this fluid, we send the fluid either for cytopathology if we have to rule out some malignancy, or we can send it for pus culture if it is an abscess aspiration. So this is a simple cyst aspiration. Now coming to the most important section of breast interventions, which is the biopsies. Biopsies are very important these days because whenever we detect a lesion in the breast, we have to, of course, rule out whether it is malignant or whether it is not. So now there are some confusing biopsy terms which might not be clear in the initial start of your practice. What is core biopsy? What is true cut biopsy? We keep on hearing different names. Then we have punch biopsies, incisional and excisional biopsies. So a little bit about what is core biopsy. Core biopsy is performed with an automatic spring-loaded gun, which is introduced into the mass or the target, and then its automatic spring-loaded mechanism cuts through the lesion. And we obtain a core of tissue from inside that mass. And what is true cut biopsy? True cut biopsy is also a sort of core biopsy, but the true cut needle is a semi-automatic gun. So what is semi-automatic? It is for targets where when we move towards the lesion, then a little bit of manual component is there that we have to push in the needle into the target. We have to push it manually into the mass and then we fire the gun. So this is a little bit of semi-automatic mechanism. It is used when we have some important lesions like surrounded by vascularity, or we have to avoid adjacent structures. Then we use this semi-automatic true cut needle, but it is also a core biopsy only. Now, punch biopsies are performed by dermatologists for skin. There is a special punch biopsy forceps. And incisional and excisional biopsies, of course, are performed by surgeons whenever they need to take out the whole lesion. But most of the times, ultrasound guided percutaneous biopsies suffice. So indications of breast biopsy. The indications for breast biopsies are all suspicious lesions in the breast, which are suspicious for malignancy or highly suggestive of malignancy. So they are all BI-RADS 4 and BI-RADS 5 lesions. I'll not be going into details of BI-RADS 4 and 5, but yes, any irregular mass, taller than wide, heterogeneous echo pattern, microcalcifications, architectural distortion, patient coming in with a retracted nipple, skin thickening, lymph nodes in the axilla, all these are BI-RADS 4 and 5 characteristics, and we have to go ahead for breast biopsy in these cases. So now what are the pre-procedure prerequisites of the breast biopsy procedure? A written informed consent from the patient explaining her all the details of the procedure. the risk of any bleeding or infection, and most importantly, confirming the side of the breast of the patient is very important. Then you have to take history of anticoagulants from the patient. If a patient is on simple blood thinner like ecosprin, you may not stop it because breast is a soft tissue structure. We can always give a few minutes of more compression to stop the bleeding if at all it occurs. But if yes, she is on anticoagulants for some other cause like DVT, then you may stop it in consultation with the clinician who is treating her, or get a PT-INR done a day before the procedure to see whether her bleeding profile is normal. Then all these procedures are performed under local anesthesia, which is 2% lidocaine. A little bit about the biopsy guns, as I have already spoken. This is a core biopsy gun, which is automatic spring loaded, and this is a semi-automatic gun. Both of these guns are by BARD, which is the most common biopsy gun which is used for the breast procedures. And see what is this color code? This color code depicts the gauge of the needle, the thickness of the needle. So like this is pink, this is 18 gauge, this is 16, the purple one, and the green one is the 14. Now this green is important for breast biopsies. Why? Because internationally it is recommended that all breast biopsies should be performed with a 14 gauge gun, so that a thick, nice core of tissue is obtained for a good histopathological diagnosis. And since bleeding is, as compared to the internal organs, not much of a risk in breast because it can be compressed very well, so we can perform it with a slightly thicker needle also, which is the 14 gauge. Now this is a semi-automatic true cut needle. In this also, see, this is also the firing mechanism, but we have this 0 mark, if you can see here. It has a 1 centimeter and a 2 centimeter notch. The throw of the needle can be controlled. We can adjust it to 1 centimeter if the lesion is small, or to 2 centimeters if it is compatible with 2 centimeters. Then it is also a coaxial, it has a coaxial needle. This is a cannula from where we can place this cannula at one place in the organ which we have to biopsy, and then through this cannula we can pass this semi-automatic gun and take tissues repeatedly at one site only. But in breast it is not that important. It is especially important in lungs, where we have to avoid pneumothorax. Now, I will be demonstrating short videos of the use of the hardware also for the beginners. Now, this is the biopsy gun. It comes like this in a packet. We load it by pressing these 2 buttons, which are here. Push out the lock. It has a lock here. And then fire it with this front button, or we have a back button also. So loading with 2 buttons, firing with front or back button. And then to expose the sample notch, we press it single button only. So loading by pressing 2 buttons, and sample notch exposure by 1 button only. So now see, this is the sample notch where the tissue is here, and we put it in the formalin bottle. Now again, see the technique of the biopsy. The probe is held firmly against the tissue. We see the lesion. Be stable in holding your probe. Hold it at an angle, and then we can see the needle. This was a papillary lesion with a cystic and a solid component. We are targeting the solid part of the lesion. And see, we can see the needle well, and when we position, when the needle lesion is smaller, we can keep the needle at the periphery, because the throw of the sample notch is about 2.2 centimeters, and then fire it from periphery. Or if the lesion is bigger, we can keep it anywhere within the mass also. Now a word about what is FNAC and what is biopsy and what should we do, who wins the match. Always I have seen in practice that clinicians tend to refer patients for FNAC of the breast, and even radiologists refer for FNAC. So FNAC is fine needle aspiration cytology, which is performed by a thinner needle, and we just suck out some cells and or fluid if present within the lesion, and then we send it for examination. But internationally, FNAC is no more recommended for primary diagnosis of any mass or suspicious lesion in the breast. It's always a biopsy. But yes, FNA can be performed sometimes when you are extremely sure that yes, this is a malignant mass. You just have to prove before surgery that by you can do it by FNAC also. But for diagnosis, please don't go with FNACs. Why? Because FNACs often give false negative results also, and there is a lack of adequate aspirate from the lesions which are sclerosing, or even from malignancies which are very hard. And we have seen reports from pathologists with where it is written hemodiluted smear or lack of adequate aspirate, and then after that we again have to go for biopsy. So always try to convince your clinical counterpart or the patient for a biopsy, because it actually does not matter to the patient much in terms of procedure. You have to give local anesthesia for both. It is just that slightly thicker needle you are using. Patient will not have pain if you have infiltrated the local anesthesia properly. And moreover, FNAC cannot reliably predict invasion. It cannot differentiate between benign and borderline malignant lesions many times. And if it is malignant, it will miss DCIS or mitosis or perineural or lymphovascular invasion. So always try to perform a biopsy for the primary diagnosis of any lesion in the breast. Now, the core needle has certain minimal disadvantages. Yes, it is slightly more invasive than FNA, but really does not make a difference. Pain and hematoma can be there, but usually if you perform it with a good technique, it is not there. The turnaround time is, yes, slightly more in core needle biopsies. In FNA, we get the result the next day only, and in biopsies, it may take at least 3 to 4 days for processing of the tissue. Now coming to another set of interventions in the breast, which is hook wire localization. So what is a hook wire? A hook wire is a J-shaped wire with a hook or bent at one end, or it has two prongs at one end, which is used to localize or fix a needle or fix a lesion before any surgery. If there is a very small lesion in the breast, maybe 1 centimeter, once the surgeon opens the breast, if it is not palpable, he will be lost. There will be nothing visible where to take out the mass from. So before surgery, we actually put under ultrasound guidance a wire through this lesion, and it becomes fixed by this hook at the end. The surgeon dissects along this wire and reaches the exact tumor. So it helps in accurate localization, accurate excision and complete excision of any lesion in the breast which is smaller and not palpable. So this is a wire which I usually use. This is by Bard again, and it is called Dua lock. It has two prongs and it holds the lesion very well. A small video of the procedure again. To use the hardware, this wire comes like this in the packet. It has two prongs. Slightly the wire is out of this needle, the cannula, the shaft, and then when we open, we have to pull it inside. So it is pulled inside the two prongs to load it. So now it is loaded. Now at the end, we see that the wire has two types of rings, this twinings, the thinner one and the thicker one. So the thinner one means if we push up till here, the prongs will be deployed. So if we are pushing, see, we'll push up till here and the prongs will come out. That means you have deployed the prongs across the lesion. So now we'll see it on the ultrasound picture. This is the lesion which we have to fix. We see the hook wire is being placed. We can see the twinings of the wire, and the prongs exactly may not be visualized, but see, I'm trying to pull it and it will not get pulled with a slight pull. It is fixed now. So, and make sure that you keep your probe, the lesion nearer to your insertion site or puncture site, because the surgeon always wants to be as near to the lesion as possible. We do not actually vertically insert the wire, because we actually want to visualize the wire when we are putting it. So we have to be oblique because of the trajectory planning, but be as near to the lesion as possible whenever you are inserting the wire. So this is the mechanism of the hook wire localization. Now the next set of interventions is the breast marker clip. The breast marker clip, what is a breast marker? It is a small tiny metallic foreign body like this. These are in different shapes. It may be a coil, it may be a ring, a ribbon. So what are these breast markers? These are loaded inside this equipment, this gun, and we push it. We introduce this needle like we do any other needle into the mass where we have to deploy the clip, and either it can be deployed by this front button or back button also. Now breast, what is the indication? In Western countries or in many other countries, after every biopsy this marker clip is placed. Why? Because they may have there in West, the breast cancer is so common that they tend to diagnose multiple lesions in many patients in their lifetime, and so every time they do the biopsy they put a different shape of the marker so that they know really which side they had biopsied recently. So if they place a ribbon and that comes out to be positive, the surgeon will operate the site of the ribbon only. So that is the idea of using the breast marker clip. But in India there are no such guidelines. We usually don't put biopsy markers, very rarely we put it. And one more important indication of breast marker is before starting a new adjuvant chemotherapy. So when the patient has a large mass or she is undergoing new adjuvant chemotherapy before a surgery, then sometimes on chemotherapy the mass disappears entirely from the breast, and then the surgeon cannot trace out where the mass was and where to perform the surgery on, because surgery ultimately has to be performed. So we put a marker. See this, like this is a mass, we have placed a biopsy marker here. And then we see that the mass in subsequential scanning of during the cycles of chemotherapy, it has disappeared completely. So after 3 or 4 months, when the patient goes for surgery, we as radiologists will localize this marker, tell the surgeon, and we can in fact put a hook wire also across this marker to actually guide him where the lesion was. And then with the help of this marker, the surgeon operates the site. So now a very new kid in the block of breast interventions is vacuum assisted biopsy. So what is vacuum assisted biopsy? It is not much available still in our country. Very limited places have this vacuum assisted biopsy equipment. And it is how is it different from the core biopsy, and what are its indications? So first of all, the hardware. This has a large bore gun, a needle. We call it a probe. It is usually from 7 to 11 gauge, and usually we use about 9 gauge or 7 gauge. The function is that it has a trough here. The trough, what is the function of that? And it is attached to a machine which creates a vacuum, and it sucks the lesion into this trough. See, this lesion is pulled towards this trough, and then a cutting needle advances and cuts this mass. So what are the indications? The indications are whenever we have a very small mass, or we have just microcalcification. Sometimes we can even see microcalcifications on ultrasound, and we can actually biopsy them through ultrasound. So when it will be difficult to pinpoint our core biopsy needle to that small area, then we have to perform this vacuum assisted biopsy. So it pulls a greater amount of tissue, makes a very good chunk of tissue available to the histopathologist to examine, and sometimes even the entire lesion can be taken out by this vacuum assisted biopsy. And it is here, when vacuum assisted biopsy pulls out the entire lesion, that we need to place a marker clip after the vacuum assisted biopsy. So this is the idea: vacuum assisted biopsy, removal of the entire lesion, putting of the clip, and then surgeon operating through that clip as guidance. So again, similar image of the needle, vacuum, and then cutting needle. So the advantages: with a smaller needle, it allows accurate diagnosis with a larger amount of tissue. Replacement of excisional removal of fibroadenomas is the indication, and it is being used with quite a lot for the removal of smaller fibroadenomas, wherein you can entirely avoid doing surgery for the patient for about 3 to 4 centimeters of fibroadenomas. Now this is again a small video of a procedure. You can hear the sound of the machine. This is the needle with the trough, and we see that the needle is advancing to cut it. Now on the screen, this patient had nipple retraction, young patient. We had done a core biopsy, but nothing was coming on it. So we actually planned a vacuum assisted biopsy to make sure whether we are missing any cancer, because nipple retraction was quite a lot, and she had a lymph node also in the axilla. So see that we have advanced this vacuum assisted probe here, and see the lesion is pulled in the trough, and then the needle will advance here to cut it. So we obtain a large chunk of tissue, and luckily this patient had only some evidence of granulomatous mastitis, which was causing her nipple retraction, no malignancy. So this was all about breast interventions. I would say that all the radiologists who want to perform actually should go with it. Get on your mask, get set, and go and start doing all these little procedures. It's not difficult at all. And any one of you, if anyone has query, they can contact me anytime on my phone or mail. I will be ready to solve their queries for the use of hardware, equipment, how to procure, and whatever problem they have. So thank you all for listening. Thank you so much.
A very nice and informative talk by Dr. Parul. And I think we have become more wiser now with your talk, with the latest in the breast intervention. And I want to ask you, Dr. Parul, can we use your interventions for saline or silicone breast implants?
Sir, when we have any silicone breast implants, we have to be careful in using all our interventions so as that we are not puncturing the silicone implant, but yes, we can perform the interventions.
Okay. We can use this technique because after putting the implants, we can fill it with the saline or gel. No?
What, sir?
In saline breast
implants already contains silicone. So whenever we are doing any breast intervention or inserting a needle, we just have to be careful in inserting our needle where we are actually inserting it.
Thank you very much. Very nice information and latest in interventions, because breast carcinoma is becoming very, very dangerous in India. It's the leading cause of deaths, as I was told, and it is surpassing the cervix and oral cavity cancers. Thank you very much.
Thank you so much, sir. Thank you. Thank you all.